Assalamu alaikum. Good morning, everybody. It's my pleasure today to present this lecture about stress echocardiography. This lecture is part of our academic activity here in the department, and I hope the diversity of the topic that's presented here could get the benefit for everybody to refresh the information and be in the academic review for the most needed topics. So, stress echocardiography, it is an effective method for the evaluation of the myocardial ischemia. And this is basically by detecting any regional wall abnormality that induced by stress. The data suggestive the accuracy of the stress echo, it's about 80 to 90%, and we found it's superior to the exercise stress test in terms of diagnosis. It is very safe, and we are talking about only mortality of 1 in 1,000. There is some meta-analysis, it's very old meta-analysis, trying to compare exercise stress test versus exercise SPECT with a nuclear medicine, and we found that we are talking about specificity of 77%, which is superior to the SPECT in the specificity and sensitivity of 85%. So it's very good modality and accurate as well. And it is basically based on the detection of two of the ischemic cascade. We are talking about diastolic dysfunction and systolic dysfunction, and this induced by stress. The importance of stress echo, it can differentiate between the viable myocardium and the scarred myocardium, along with the defining the ischemia manifested by regional wall abnormalities. Usually the indication, if you have patient with stable symptoms or patient post-myocardial infarction, just to assess the viability, very operative, some patients who are with elevated risk. Also the assessment of myocardial viability and hibernation with reference to planned myocardial revascularization, and the assessment of severity of structural heart disease like HOCM or aortic stenosis. The contraindication, any unstable patient, either with an unstable angina, severe baseline hypertension, uncontrolled arrhythmia, if the patient have mobile LV thrombus, or patient with acute decompensated heart failure. For the aortic stenosis, if the patient is already symptomatic and is known to have severe aortic stenosis, they're contraindicated along with the HOCM. What's the stress modality? Now we are talking about, we need a modality that assess the demand supply mismatch using the stress to estimate the response of the myocardium to the stress. We have many modalities. It could be medication, pharmacological stress test, or exercise using the treadmill or bicycle, the supine one, or sometimes pacing can be used to assess or to induce the stress. And this stress can be manifested either by metabolic abnormalities like what we are seeing in the PET scan, or regional one abnormality as in the echo, or change in the ECG like in the exercise stress test, or symptoms, which is very, very important factor or determinant of the response to the stress. This is one of the modality, which is the supine bicycle. We can try to compare what's the advantage and disadvantage of each stress modality, like we're talking about the treadmill. It's widely available, high workload. The problem, the disadvantage is post-stress imaging, mild ischemia may be missed. Upright cycle imaging during exercise, it's a little bit technically difficult. The supine, the workload is low, it might take a long time. The dobutamine, it's very effective and efficient, but the problem with the side effects, some patients cannot tolerate the dobutamine. Dobutamine is recommended as a first-line agent for pharmacological stress echo by the American Society of Echo. And it can increase the chronotropic and the blood pressure. The half-life of dobutamine up to 2 to 3 minutes. That's very good drug, and low dose sometimes can cause positive inotropic effect through both alpha and beta. And that's why sometimes can cause hypotension at the beginning. Higher dose cause more chronotropic effect, specifically through the beta-2 receptor agonist. The side effect of the dobutamine, it could be arrhythmia is the most common and most serious. Cardiac arrest, MI, it's very rare. We're talking about mortality of 1 in 1,000, but still can happen. Tremor, nervousness, marked hypotension. This is one of the common side effects in dobutamine stress echo. In this video, we are going through how to prepare the patient for stress echocardiography. This video from Leeds Teaching Hospital explain to you how to prepare the patient for such test. As you see here is attached to the monitor, trying to get the baseline ECG, determining the underlying rhythm, then getting the baseline transthoracic echo and transthoracic imaging to have an idea, then getting an IV access. It's very important here. Sometimes we might use a contrast to delineate the LV cavity and give us like more accurate, we can say, images to assess the ejection fraction or any regenerative. It's very important to explain to the patient what the expectation during the stress test and what's the possible side effects that might have happen. Usually we are using the pump IV access or pump infusion to deliver the drug and to increase the dose of the infusion based on the followed protocol. And this is very important to reassure the patient, try to like stress on the possible side effect that he might have, informing him about what's the outcome of this study, reassure him, because like it's as similar to the other procedure. One of the things that we are keep following during this the test is the ECG along with the blood pressure monitoring throughout the study. But still, like human error has both stress safety since human begin to deal with technology, and this can happen even these days, even with advanced technology. That's why it's very important to have a protocol and to have make sure that you have done things. Usually the protocol 4 hour fasting before the procedure, all negative inotropics and economic should be held for 8 to 12 hours. IV access for sure, baseline imaging is obtained, continuous ECG and blood pressure monitoring throughout the protocol, and we usually start the dobutamine 5 up to 10 microgram per kg per minute, and this increased by 3 minutes as to the other protocol used in any stress modality. Atropine sometimes can be used as an augmentation if we didn't achieve the target heart rate. And getting the big image is very, very important after the return to the baseline, and keep monitoring your patient. This is one of the protocol that's with the increasing the dose every 3 minutes, increased by 5 microgram per kg per minute, up to reach the maximum dose, and we can use the atropine as augmentation to achieve the target heart rate in case not achieved. When we should stop the dobutamine infusion? For sure, if you exceed the 85% of the target heart rate, develop significant angina, recognition of the new wall motion abnormalities, or positive stress echo, a decrease in the systolic blood pressure more than 220 millimeter mercury from the baseline, a sustained or symptomatic arrhythmia, limiting side effect or symptoms, and severe hypertension. It's very important to talk with your patient during the procedure just to know what does he not, especially with from symptoms point of view. Safety, it's been studied for in many studies, and severe cases, it is short acting. IV beta blocker can help you to reverse the effect of the dobutamine, and again we are talking about 1 in 1,000 as a mortality rate. The most limitation is the false negative, suboptimal stress, or limited imaging quality. Small area of ischemia can be there, and this will affect the specificity of this study, along with the challenging like left bundle branch block, which can affect the, or any conduction abnormality can give you a septal regionality, postoperative status, like post-CABG also. This can present with some regionality that you can differentiate. This is because of the ischemia or something is there. To interpreting the drug for dobutamine stress echo, we are using the 17 segment classification, and based on this segmentation, we can assess the regional wall abnormality and the culprit vessel at the end. And also, this is very helpful in case of revascularization to guide us which myocardium is viable, which myocardium is already done. And usually the response could be either normal or hyperkinesis, which is normal response to the stress, or sometimes lack of hyperkinesis like myocardial ischemia. Non-ischemic canalopathy or dilated canalopathy can cause the same. If the patient already in beta blocker, this will affect the response to the stress and improving contractility. The volume response is another response other than regionality, decrease in the end systolic volume and in the diastolic volume, and this is the normal response for the dobutamine. And usually the decrease, it's up to 30%. But an abnormal volume response is defined as increase in volume from rest to stress up more than 17%. This could indicate abnormality in the volume response to the stress echo. Contrast echo is very, very important, especially in case of the we have a limitation with the resolution, and it's very important to delineate the LV cavity and define the regional wall abnormalities in such cases. The regional wall abnormalities we are talking about either infarction and the ischemia, they have the same response at rest or stress. Cardiomyopathy, you will have it at rest, and transitional cardiac movement at the stress. In myocarditis, you will markedly increase blood pressure, left bundle, cardiomyopathy, rate-dependent left bundle, hypertension. All of these can presented with regional wall abnormalities. What's the response? The normal response usually with the stress, you will find hyperkinetic and normal during the rest. Also, hypokinesis and akinesis, this could represent ischemia during the stress. If the patient have an akinetic segment at the rest and still it's akinetic in the stress, this is already infarcted. If the patient have hypokinesis and in the rest and it became normal during the stress, this could indicate a viable myocardium. If the patient have hypokinesis and this hypokinesis get worse, like became dyskinetic or akinetic, this also indicate ischemia versus function. This is one of the example for the Dobutamine stress test and confirmed with the angiogram. We use the crust to delineate the alveolar cavity, and as you see, the apex here, it's a little bit hypo, or it is dyskinetic, and this could indicate what we are seeing here in the angio with distal LAD occlusion. I will conclude with this, and thank you very much for your attending, and looking to see you again. Thank you very much.